Hello, everybody. Today we're going to talk about a rare type of a neuroendocrine tumor by name glucagonoma. Despite being uncommon, it is important to understand the basics as about half of the patients would have had metastasis at the time of diagnosis. So let's explore this topic in a clear and informative way. But kindly hit the subscribe button and let's get started. So, glucagon is a peptide hormone produced by the pancreatic alpha cells, and they actually act as a catabolic hormone in order to increase the blood glucose. Well, unlike insulin, which promotes the storage and uptake of glucose, glucagon will rather stimulate the breakdown of glycogen to release glucose into the blood. So, excessive insulin is equal to hypoglycemia, but excessive glucagon is rather equal to hyperglycemia. Now let's take a look at two important processes. So we have proteolysis, which is the breakdown of proteins. Now, during proteolysis, glucagon signals the breakdown of these proteins into a glucogenic amino acid supply. That supply chain is going to be used by the liver to make glucose, a process we call gluconeogenesis. So, in summary, excessive proteolysis is going to increase the blood glucose. On the other side, we also see lipolysis. So, the effect of glucagon would lead to the breakdown of these lipids, and we're going to have glycerol and free fatty acids. Well, glycerol is also going to be used by the liver to make glucose, again, the process of gluconeogenesis. And the free fatty acids can be used in beta oxidation to form ketones. So the take home point is that you wouldn't be surprised to see a patient with glucagonoma having glucose intolerance or diabetes mellitus. Necrolytic migratory erythema. This is a cutaneous manifestation commonly seen in patients with glucagonoma. The exact mechanism underlying this rash is still not fully understood, but it is believed that a low zinc and essential fatty acids have been associated with the development of necrolytic migratory erythema. It may also be the only presenting complaint in the early phase of the disorder. So generally, the rash may present as a brownish erythematous superficial and exfoliating rash with signs of necrolysis in the epidermis. The rash may be painful, pruritic, and it heals with hyperpigmentation. So the patient with glucagonoma has excessive glucagon levels that leads to a higher catabolic state. That will certainly lead to proteolysis, which is the breakdown of the proteins into amino acids and nitrogenous compounds. The amino acids are then used by the liver to make glucose. So this would lead to a decline in amino acids, which is going to be called hypoaminoacidemia, which may actually be a prominent feature of glucagonoma. Now, once amino acids are decreased, this would also lead to a decline in transport proteins such as albumins. Albumin is a major carrier for essential fatty acids as well as zinc. So, in the absence or when albumins are declined, that would also reflect in the low levels of essential fatty acids as well as zinc. Now, both essential fatty acids and zinc play a critical role in the maintenance of skin trophism. So there is also a lack of peptides from the hypoaminoacidemia, which will certainly affect epidermal skin maintenance. Now, this regulation or a low zinc state can actually lead to a disbalance of prostaglandin synthesis that can lead to inflammation in the epidermis as well. All right, so here we'll take a brief look at some reactions that tries to explain the role of zinc in necrolytic migratory erythema. Although we mentioned that hypoaminoacidemia leads to a diminished synthesis of peptides in the epidermal tissues, zinc also seems to play a major role in the skin rash associated with glucagonoma. So what we have here is linoleic acid, which is a primary precursor, also known by the name omega 6. This is converted into arachidonic acid. Now, how does this occur? So there is the enzyme delta 6 desaturase, which converts this primary precursor omega-6 into gamma-linolenic acid. This is subsequently converted into dihomogamma-linolenic acid, which I would be referring to as DGLA, by the help of the enzyme elongase. And finally, delta 5 desaturase converts this DGLA into arachidonic acid. Well, the reason for zinc being important is that zinc is a cofactor for this reaction. So for this to be very effective and efficient, we need zinc. And so without zinc, there's going to be a blockage, or this reaction is going to be inhibited. Now you recall that zinc is decreased in glucagonoma because there is hypoaminoacidemia, and there is also a decline in transport proteins that carries the zinc. Now, not only zinc, you also have to understand that in the face of excessive glucose, this can also affect these enzymes such as desaturase. In other words, hyperglycemia may also lead to inhibition of this reaction. So it may actually seem that this is going to lead to a decline in the production of arachidonic acid. Well, that may be true, but you have to understand that there is also phospholipid membranes that contains arachidonic acid that can also be released by the phospholipase enzymes, which can also produce arachidonic acid. So in short, there is going to be a diversion to form arachidonic acid, which will lead to increased production of inflammatory mediators. And there is going to be a disbalance between series of prostaglandins. So watch this. Now you see that DGLA is converted into series 1 prostaglandins. These are actually good prostaglandins that actually helps fight inflammation. So they are anti-inflammatory. But if you look at this, you can also see that the diversion will lead to excessive formation of arachidonic acid. And there is going to be the formation of series 2 prostaglandins that are rather pro-inflammatory. So there is a disbalance between these series of prostaglandins, and this will determine inflammatory impairment of skin epidermis, especially at areas exposed to abrasions or friction, such as the buttocks, the groin area, the perineal, the feet, or the legs. Well, another theory also links necrolytic migratory erythema to a reduction of tryptophan in the cutaneous tissue as a result of the excessive glucagon levels. So we see tryptophan, which is a primary precursor for niacin. Niacin is also known as pellagra preventing vitamin. It is also a precursor for serotonin. So a reduction or tryptophan deficiency would lead to what we call the 3Ds, that is dementia, dermatitis, and diarrhea. In fact, in glucagonoma, we can also see these symptoms with this disorder. Oral impairment. There is cheilitis, which is inflammation of the lips. There is painful as well as atrophic glossitis, and stomatitis, which is inflammation of both the lips and the mouth. Diabetes mellitus. So glucagonoma associated diabetes mellitus may be considered in any new onset or worsening diabetes mellitus. Diabetes mellitus in this case is generally mild or may present as an impaired glucose intolerance. Glucagon especially induces hyperglycemia if there is a pre-existence of an impaired glucose metabolism by the liver. Normochromic normocytic anemia may also be a clinical manifestation of glucagonoma. It could likely be secondary to the severe weight loss and the inhibited red blood cell production due to the catabolic effect of excessive glucagon. Diagnostics. So a comprehensive clinical history is necessary. Usually, glucagonoma may present with a triad of diabetes mellitus, necrolytic migratory erythema, and weight loss. Sometimes as far as 5 to 15 kg may be lost. There is usually a deficiency of all macronutrients, especially with the proteins. The carbohydrates and fats are also affected. Occasionally, necrolytic migratory erythema may be the only presenting sign, so please be aware and take this skin rash as a serious one. Blood work. Now, if fasting glucagon levels greater than 500 picogram per ml is diagnostic. However, the levels are usually way beyond that. Reference range is between 70 and 160 picogram per ml, but do well to consult your local protocol. It's important to also consider a fasting blood glucose as well as the glycated hemoglobin, as diabetes mellitus is associated with glucagonoma. A complete blood count may help you assess anemia as in this case, you see a normocytic and normochromic anemia. Now, regarding serum chromogranin A levels, these are very sensitive markers. What are these? They are just granules that are produced and packed in secretory vesicles of neuroendocrine tumors or cells. In this case, this is a glucagonoma. In theory, the levels may also help tumor response assessment to therapy. In fact, it's necessary to also consider multiple endocrine neoplasia 1, as this is also associated in 10% of the cases with glucagonoma. So you recall that MEN1 consists of pituitary tumors, parathyroid hyperplasia, and pancreatic tumors. So it will be important to assess the insulin levels, calciums, vasointestinal peptides, as well as prolactin. And a glucagonoma is often associated with liver metastasis by the time of diagnosis, hence a liver function test is also necessary. Somatostatin receptors and glucagonoma. So this rare type of tumor right here, which is a glucagonoma, expresses somatostatin receptors on its surface. In this case, we are looking at a subtype 2 receptor right there. We are also looking at a subtype 5 receptor on its surface. So we want to do a PET scan and we want to enhance the image. What can help us is that octreotate naturally can bind to the receptors. So we want to target the receptors on the tumor by binding the octreotate to a metal that is a gallium 68. And how do we bind it? Well, we use something called daughter. Daughter is a chelate. So a chelate is something that sort of binds a molecule or an ion to the metal. So this is a complex. And as I said, naturally, octreotate can bind to the receptors. But now we have a chain, we have a metal that is connected to the octreotate. So it goes together with it and it will bind to the receptor. Well, when that happens, the effect is that this enhances the imaging on the PET scan. This is not only used as a diagnostic technique, but can also be utilized in therapeutic modalities such as a peptide, receptor, radionuclide therapy, where, say, the gallium is replaced with a radionuclide with the aim of targeting and killing the cells. So, imaging modalities may include a positron emission tomography with gallium 68, and this is actually preferred unless they are not available. In general, a contrast enhanced CT of the abdomen can also be very useful. A gadolinium enhanced T2 MRI of the abdomen can be very necessary, especially if there is the need to differentiate this type of tumor from a pancreatic adenocarcinoma. Selective angiography of the celiac axis as well as somatostatin receptor scintigraphy are all useful in the diagnosis. Biopsy. So, what is a grading Ki67? This is actually known as a mitotic index, and this refers to the grade of cell division. So, it is a very good proliferator marker for grading neuroendocrine tumors. Both the European Neuroendocrine Tumor Society guideline as well as the WHO classification have a similar grading system. Grade 1, 2 or less percent cell division. Grade 2, that is between 3 and 20% cell division. And grade 3 is greater than 20% cell division. This is important because this may influence treatment. While in advanced cases, a skin biopsy may also be taken, and this may show a necrolytic lesions in the epidermis. There may also be a psoriatic resemblance in the epidermal tissue, such as a hyperplasia and keratinocytes. Inflammations in the perivascular spaces may also be seen. Management. Surgical resection is the only curative treatment modality for regionally localized glucagonoma. Somatostatin analogs helps reduce the catabolic state, ameliorate the necrolytic migratory erythema. It is also used as the first line in palliative treatment for patients with unresectable tumors with metastasis. The chemotherapy with streptozotocin, 5-fluorouracil, and doxorubicin may be tried, however, the responses are usually poor. Everolimus and sunitinib, as well as a peptide receptor radionuclide therapy, may also be used. Thromboembolic prophylaxis is necessary as glucagonoma is often associated with such events. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.